So now it's time to have a debate about HER2 low. Is it a separate clinical biologic entity? For the pro side, we are pleased to have Giuseppe Curigliano from the European Institute of Oncology. He's Associate Professor of Medical Oncology at the University of Milano and Head of the Division of Early Drug Development at the European Institute of Oncology in the IRCCS, Italy. He is a clinician and researcher specializing in early drug development for patients with solid tumors with a special commitment to breast cancer. Giuseppe?
So thanks a lot to the moderators and organizer for inviting me for this challenging debate. So in the next 20 minutes, I will try to convince you that HER2 low disease is a separate entity. So I will support the pro. So let's start with the interactive poll. So is HER2 low a separate entity? So you should vote on your device, yes or no. Proceed with the poll.
And the way to vote on your device is go to this session, go to Dr. Curigliano's presentation, and at the bottom there'll be a place to vote.
You have to click the button.
You have to click the button. Start the button. Yeah.
So A is yes, and no is, of course, no. We don't have the vote.
So we'll have it at the end.
Okay, we will have it at the end. So let's try to convince you that it's a separate entity. Those are my disclosures. So let's start from basic. So how do we define HER2 low disease? We had an excellent presentation from Professor Rim. Up to now, we can define HER2 low disease as an immunohistochemical 0, 1+, 2+ with fission unamplified. So, we know perfectly that we have a treatment choice for immunohistochemical 1+ and 2+ with fission unamplified. Actually, we don't know if we can use a specific treatment for HER2 negative or HER2 0 that can be defined as something between 0 and 1+. So what would justify HER2 low as a separate entity? So I will try to address 3 points. The first one is related to prognosis. Do we have a unique prognosis for the entity? This is the first question. The second one is the clinical impact of therapy. So do we have a unique treatment plan for the entity? And finally is the classification of this entity. Do we have a unique biology for HER2 low and a reliable, robust assay to define the entity? Let's start with the prognosis. So I tried to summarize all the abstracts that have been presented also during San Antonio, but also to support other papers that have been published in the past. We know that many studies have been conducted in the last years in order to understand if is there a prognostic role for HER2 low expression. In the majority of the cases, there was no overall survival difference when comparing HER2 low to HER2 0. But we know that in some studies that, in my opinion, are very interesting, you can define specific differences. I would like to mention this pooled analysis of HER2 low tumors in 4 German breast group trials. Here, Carsten Denkert evaluated clinical and molecular characteristics of HER2 low breast cancer in the context of prospective randomized trial. Here we have the trials, 3,512 patients in the GEPAR-SEPTO, GEPAR-OCTO, GEPAR-X, and GAIN-2. Starting from the basic definition, in the context of the trial we have 1,200 HER2 positive tumors that have been excluded. And then we have HER2 negative, HR negative, that finally are 33%, and HER2 negative, HR positive, that are again 33%. When evaluating their HER2 low subgroup, we have 395 patients HER2-low HR negative, and 700 patients HER2-low HR positive. So it's more frequent to have HER2-low disease in the HR-positive disease. What's about clinical and pathological differences? Just looking at pathology, in HER2-low disease, we have less grade 3 tumors and lower proliferation. This is perfectly in line with the TALENT trial. Also in the TALENT trial, you saw that in their HER2-low population, there were less grade 3 tumors. What's about prognosis? We have an improved disease-free survival for HER2-low tumors, in particular in the HR-negative subgroup. When you compare HER2-0 to HER2-low, the prognosis was better for HER2-low disease. And the improved disease-free survival for HER2-low tumors in HR-negative breast cancer was driven by no PCR group. Here, the delta is really statistically significant. So if you don't have a PCR and you have a triple-negative disease, the prognosis is better in their HER2-low population. It's an evidence retrospective analysis, unplanned from prospective trials, but this is what the German breast group observed. In the poster presentation today, you will find this Daniel Pfeiffer poster, in which there is a real-world analysis of HER2-low breast cancer across stage, from stage 1 to stage 4. And also here, HER2-low status is associated with marginal improved survival, particularly in triple-negative breast cancer. A small decrease in PCR was also observed in their HER2-low disease. Of course, this is unclear because this is a real-world analysis, and this is not enough to justify the classification as a unique entity. Another interesting poster of Harriet Rothschild is related to the evaluation of HER2-low in lobular cancer. This is a very interesting observation. Patients with HER2-low invasive lobular cancer had worse disease-free survival when compared to HER2-negative. Patients with HER2-low ILC were more likely to undergo mastectomy, but those are lobular cancer, and usually they have much more expression of progesteronic receptor. What's about the clinical impact? Here is very easy for me. We have a drug approved for HER2-low disease according to the data of the DESTINY-04. Patients included were immunohistochemical 1+ and 2+ with FISH non-amplified. And in the context of a prospective randomized trial, a drug was tested that was trastuzumab deruxtecan, having as primary endpoint progression-free survival and key secondary endpoint PFS and overall survival. And there is a dramatically benefit of trastuzumab deruxtecan when compared to standard chemotherapy that was independent from the expression of HER2. In 1+ and 2+, there was absolutely the same benefit in progression-free survival and overall survival. And there is also an improvement in HR-negative disease. Here we have the data of TDX in the small cohort of patients with HR-negative disease. What's about other studies? This is again the study of the German breast group. In their HER2-low tumors, we have a reduced PCR rate, specifically in the HR-positive subgroup. This is a little bit different from the data of the TALENT, but it's interesting to understand that if you have an HER2-low disease, an HR-positive disease, you have less pathological complete response. In this other study from an Italian group, if you receive a CDK4/6 inhibitor in the metastatic setting and you have an HER2-low disease, usually the outcome is worse in the HER2-low population. What's about other posters? This is very interesting. I suggest to you to visit in the poster session. The German breast group performed an outcome analysis of HER2-0 or HER2-low hormone receptor breast cancer patients in the Penelope B trial. And this is an analysis for 1,119 patients for which we have paired biopsies at baseline and the residual disease after surgery. And for 540 patients, we have a specific mRNA data with HTG analysis. A shift from HER2 low to HER2 zero was not associated with a significant survival difference. But when you have a shift from pre-neoadjuvant chemotherapy HER2 zero to post-neoadjuvant chemotherapy HER2 low, there is a significantly reduction of invasive disease-free survival compared to the persistently HER2 low group. Here is very clear, HER2 low to HER2 low, this is the outcome. HER2 zero to HER2 low, there is a completely different outcome. Again, molecular subgroups have been analyzed here, and there is a significant invasive disease-free survival difference for HER2 low status when combined AIM subtype, so luminal B basal HER2 enriched versus luminal A or normal like. So patients post-neoadjuvant chemotherapy HER2 low tumors had an improved survival in aggressive subtypes. So if you have a luminal B basal or HER2 enriched, HER2 low, it's completely different from not HER2 low. And here we have the outcome, finally, comparing HER2 zero versus HER2 low. What's about HER2 mutation? This is a common question. Why? Because we know very few patients with breast cancer, mainly HR positive, without HER2 amplification, can be HER2 mutant. Those are the most frequent mutation in breast cancer. You know that in lung cancer, the approval of trastuzumab deruxtecan was for HER2 mutant non-small cell lung cancer, and the majority of those tumors have no detection of HER2 expression or gene HER2 amplification. So the approval is only for HER2 mutant. We don't know nothing in breast cancer about correlation of HER2 mutation and specifically the activity of trastuzumab deruxtecan. Those are some preclinical data in non-small cell lung cancer cell lines xenograft model, and it seems that some HER2 mutation may predict ADC internalization. There is much more activity if the tumor is HER2 mutant. We have some data from the Aurora trial. In the Aurora trial, you have matched baseline tissue sample and metastatic disease. And usually, you may have an enrichment of HER2 mutation in the transition from HER2 zero to HER2 low, but very limited data to make a conclusion. This is a very important point because sometimes you may have two mutations on the HER2 domain that may increase the activity of the HER2 pathway. And you know we have data from Matthew Ellis and also data from David Hyman demonstrating that tyrosine kinase inhibitor can block this pathway with an upregulation of the PI3 kinase pathway. So I believe we need to understand much more on this. The final point is, can we define a separate entity as a unique biology and reliable, robust assay to define the entity? Looking at the data, finally, usually HER2 low positive tumors have less grade 3, they have a lower proliferation, and they have less P53 mutation. This is from the biological point of view. In this poster session, an analysis has been performed by Clinton Yam. You will see here that some genes involved in fatty acid metabolism and steroid hormone metabolism can be upregulated in HER2 low versus HER2 zero tumors. And again, when evaluating pre-neoadjuvant chemotherapy and post-neoadjuvant chemotherapy, there is an upregulation of genes involved in epidermal growth factor receptor ligand in the pretreatment HER2 low tumors with no PCR after neoadjuvant therapy. So in stage 1-3 triple negative, low HER2 expression is associated with increased androgen receptor expression. Gene expression analysis suggests that drivers of resistance to neoadjuvant chemotherapy can be different between HER2 low and HER2 zero. And we need, of course, to explore much more on this. Another paper demonstrated a PI3 kinase mutation rate higher in HR-negative HER2 low disease. And finally, in the German breast group analysis of the Penelope B, using the HTG oncology biomarker panel, 52 genes were significantly correlated with the post-neoadjuvant HER2 status and may differentiate HER2 low versus HER2 zero. So what we have to do to detect better the HER2 low disease? So do we have a test? we listened already about the use of the aqua system in order to better quantify their two level as a continuum between 0 and 3+. And it's also important that we have some deep learning methods for HER2 low detection. So you can use artificial intelligence with cell analysis system to better discriminate between HER2 0 and HER2 1+. Of course, the limitation here is immunohistochemistry, because in any case, you use immunohistochemistry and you learn to the machine to identify the area to detect their HER2 low status. I don't know if this will be the future. It's very complicated to bring this in clinical practice, but targeted mass spectrometry with the proteomic analysis maybe can differentiate HER2 status at the protein level. And here you can see that sensitivity and sensibility is higher. Also, the high field asymmetric waveform ion mobility spectrometry seems to be better to identify HER2, but I don't believe this is feasible in clinical practice. So coming back to the initial question, is HER2 low a separate entity? In my opinion, HER2 low is a separate clinical entity, and we need to reconcile limitation in trial design that excluded patients that were immunohistochemical 0. We have an obligation for our patients to make these valuable clinical annotated specimens available for high priority secondary correlative studies with assays that are analytically and clinically validated, and that could help us better to define who are the patients most likely to benefit from these exciting treatments. We know that there is activity also with immunohistochemical 0. This is the DAISY trial. We have overall response rate of 30% with a median progression-free survival of 4.2 months. And we have a huge amount of patients that have been included in the DESTINY-06. The cohort was planned for 150 patients, but was expanded because this is the main question. If you may have activity in HER2 ultra-low between 0 and 1+, and the DESTINY-06 will answer to this question. So is HER2 low a separate entity? It is more common in HR-positive breast cancer. We have a reduced PCR rate in HR-positive breast cancer. HER2 low tumors have the option to switch between ER signaling and HER2 signaling with the crosstalk as a result of exposure to therapy. And we have an improved survival in HR-negative breast cancer, specifically non-PCR tumors. So in my opinion, HER2 low is a separate entity. We have a treatment which makes it a relevant entity with progression-free survival and overall survival benefit. We need, of course, to further study the HER2 low separate entity because we might learn about tumor adaptation to therapy. And as a biomarker, HER2 low should be standardized with a new assay. HER2 low status may reflect a biological state and not just a laboratory staining artifact, if we can demonstrate that levels of expression of HER2 may predict the response to the new ADCs. So I would like to thank Karsten Denkert and CB Loeb, of course, all these investigators that supported me with the slides, and I invite you to visit the poster session. And thank you very much indeed to the organizer for this challenging session. Thank you.
Thank you. Thank you very much, Dr. Curigliano. And now for the con of the debate, I'd like to introduce Sarah Tolaney of the Dana-Farber Cancer Institute. Dr. Tolaney, since 2008, has been on the faculty of Harvard Medical School and has been on the staff of Dana-Farber Cancer Institute and Brigham and Women's Hospital. She is a medical oncologist and clinical investigator in the Breast Oncology Center, which she currently directs. Her research focuses on the development of novel therapies in the treatment of breast cancer. Dr. Tolaney.
Thank you very much. So I'd like to thank the program committee for inviting me to participate in this special session on HER2-low breast cancer. Today I'm going to focus on why I think HER2-low is not a new subtype of breast cancer. We have known for decades now that breast cancer is not one disease, but is rather composed of different subtypes that we've put into three major groups: hormone receptor positive, HER2 positive, and triple negative. But we know within these groups there are also intrinsic subtypes that are biologically distinct and have unique gene expression profiles. Importantly, we know that outcomes do vary by subtype. And as you can see here, prior to the introduction of HER2-directed therapies, HER2-positive disease was associated with one of the worst prognoses. We have traditionally defined HER2-positive disease to be overexpression or amplification of HER2, but we've really thought of it as either positive or negative, with really nothing in between. But we've learned that HER2 testing is far more complex than this, as there is HER2 staining that can be found even within those tumors that have classically been defined as HER2 negative. This has resulted in the term HER2 low, defining those tumors that are 1+ or 2+ by IHC and not amplified by FISH. But prior to the introduction of trastuzumab deruxtecan, there have actually been no HER2-directed therapies that have been approved for HER2 low disease. So this leaves us with the question, is HER2 low a new breast cancer subtype? I would argue that it is not for the following reasons. It does not have unique clinical pathologic features. It is not associated with a difference in prognosis. It is not associated with different benefit to standard therapies, and it is not biologically distinct or biologically stable or consistent. So we'll start off with how it does not have unique clinical pathologic features. There have been several retrospective analyses that have looked at the clinical and pathologic differences between HER2 low and HER2 zero tumors. And in general, these studies have found that HER2 low positive tumors are more likely to be hormone receptor positive, be lower grade, and have lower proliferation. 2 examples of such studies are shown here, with a pooled analysis from 4 German breast cancer group trials shown to the left, and a pooled analysis from the National Cancer Database shown to the right, both confirming these findings. These findings, with differences in characteristics for HER2 low and HER2 zero tumors, however, are likely being driven by differences in degree of ER expression and not truly driven by differences in HER2 low status. We have seen several series that have shown us that as ER expression increases, so does the rate of HER2 low. In this series from the Dana-Farber Cancer Institute by my colleague Dr. Paolo Tarantino, you can see that the rate of HER2 low positive tumors does increase as ER expression increases. You can also see in this series from the University Hospitals Leuven that in HER2 low and even HER2 ultra low tumors, there is higher expression of ER compared to HER2 zero tumors. And finally, to the right in the National Cancer Database series, you also see that as ER expression increases, you also see increases in rates of HER2 low positive tumors. So when we look at differences in clinical pathologic features by ER status, we can now see that many series suggest there is no difference in these features. This is a particular series that looked specifically at metastatic patients and did look at features by hormone receptor status, and you see no difference in patient demographics or clinical characteristics between the 2 groups. So I do think that the differences that we're seeing in these clinical pathologic features, again, is being driven not by HER2 low status, but rather by ER expression. So while we can say there are not unique clinical pathologic features, there is also not a difference in prognosis. This is a large retrospective cohort from the National Cancer Database with over 1 million patients, and it looked at survival outcomes by ER status as well as by stage. And here you can see that these survival curves are largely overlapping, with only potentially very marginal differences seen in survival. When specifically looking at outcomes for patients in the metastatic setting, you also can see no distinct difference for HER2 low compared to HER2 zero status when looking by hormone receptor status. To the left, you see no difference in time to subsequent therapy, and to the right, you see no difference in overall survival. There have been numerous studies conducted to evaluate the prognostic role of HER2 low, and most of these studies have found no overall survival difference between HER2 low and HER2 zero tumors when analyzed by hormone receptor expression. One does have to be very cautious, though, when looking at these studies, as they are retrospective in nature. They have different patient populations, different sample sizes, different follow-up duration, and the majority lacked central pathology review. So these limitations could account for the marginal differences that we see between trials. I would also argue that HER2 low is not a new subtype because it is not associated with different benefit to standard therapies. When looking at impact of HER2 low on response to neoadjuvant therapy, here in this pooled analysis from the German group, you can see that there was a difference in rates of pathologic complete response in the hormone receptor positive patients, but not in the triple negative patients. Here you can see that the hormone receptor positive HER2 low tumors do have a lower PCR rate than the HER2 zero tumors. One potential explanation for this, though, could be the inclusion of ER low tumors within the hormone receptor positive cohort, because we know that ER low tumors are more likely to be HER2 zero and also are more likely to achieve pathologic complete response. So when you look at this series from the Dana-Farber Cancer Institute, when you pull out those ER low tumors, you now see no difference in any subgroup for rates of pathologic complete response. You can also see that there's no difference in benefit to chemoendocrine therapy in this analysis from the RxPonder trial. To the left, you see the premenopausal patients, and you can see that chemotherapy followed by endocrine therapy did lead to a numerical improvement in invasive disease-free survival for both HER2 low and HER2 zero subgroups, whereas to the right in the postmenopausal patients, you see no benefit for the addition of chemotherapy, irrespective of HER2 low status. This is very consistent with the overall trial findings, really suggesting that HER2 low status should not be used to make therapeutic decisions in this patient population. We do, however, see conflicting results for the benefits of CDK4/6 inhibition by HER2 low status. In the series to the left, looking at a pooled analysis from 6 Italian cancer centers, you see HER2 low was associated with worse progression-free survival and overall survival compared to HER2 zero patients in the first-line setting for people getting endocrine therapy with CDK4/6 inhibition. To the right, in a larger series from the MD Anderson group, you now see no difference in progression-free survival or overall survival for a similar patient population. I think this highlights that there are limitations of these retrospective analyses and could account for the discordance when you're looking at retrospective data where there's no central confirmation for HER2 low status, again, in my mind, suggesting that there are likely not larger differences in benefits to CDK4/6 inhibition by HER2 low status. So while we can say that there are not differences to chemotherapy and endocrine therapy, what about differences to HER2-directed therapy, with the classic example being trastuzumab? NSABP B47 tried to address this question and took patients who had HER2 low tumors and randomize them to get chemotherapy with or without trastuzumab in the adjuvant setting. And you can see that there was no improvement in invasive disease-free survival or even overall survival when adding trastuzumab to chemotherapy, really suggesting that trastuzumab does not add benefit to patients with HER2 low disease. This, however, stands in stark contrast to what we have seen for trastuzumab deruxtecan in the metastatic setting, where we have seen that the use of trastuzumab deruxtecan did, in fact, double progression-free survival compared to standard chemotherapy and did improve overall survival. And this benefit was seen irrespective of hormone receptor status, where you see similar benefits by hazard ratio for PFS and OS. And you can see these benefits are really irrespective of IHC level, with similar objective response rates in PFS for IHC 1+ compared to 2+ patients. These data, to me, suggest that the activity of HER2-directed antibody-drug conjugates is not likely related to blockade of an oncogenic driver, but is likely due to targeted delivery of a very highly potent payload. This suggests that HER2 low is not a new subtype characterized by an oncogenic driver, but is rather a biomarker for benefit to antibody-drug conjugates that potently target HER2. I would also argue that HER2 low is not a new subtype because it is not biologically distinct. When looking at intrinsic subtypes, you can see that they are differentially distributed between HER2 low and HER2 zero tumors. Interestingly, HER2 enriched is not enriched in the HER2 low group compared to HER2 zeros. You can see it is more common in the triple negative patients and HER2 zero patients. Luminal subtypes, as shown in the blue, are more common in HER2 low and hormone receptor positive patients, whereas basal-like cancers are more common in HER2 zero and triple negative subgroups, again suggesting that the differences in subtype distribution is being driven by hormone receptor expression and not by HER2 low status. You can also see this by gene expression profiling, where you can see that the differences between HER2 low and HER2 zero are again being driven by hormone receptor expression. We can see lower expression in hormone receptor positive disease and higher expression of luminal genes in ERBB2 in hormone receptor positive disease compared to triple negative disease, just like we see with HER2 low compared to HER2 zero tumors. Additionally, we see no difference in genomic characterization of HER2 low tumors. In this series to the left from the Dana-Farber group, you see no significant differences in the incidence of oncogenic mutations after correcting for ER. Similarly, when looking at the genomics of HER2 low in this KERAS analysis, you see that the genomic status is similar to the classic subtypes that we would expect with hormone receptor positive or triple negative disease. Additionally, from the Memorial Sloan Kettering group, we also saw no difference in genomic characterization for HER2 low compared to HER2 zero tumors when analyzed by hormone receptor status, with the exception being that hormone receptor positive HER2 zero breast cancers had a higher frequency of TP53 alterations compared to HER2 low tumors, but this potentially could be due to inclusion of ER low tumors within the hormone receptor positive cohort, and Dr. Mara and colleagues have ongoing analyses to explore this. So finally, HER2 low is not a new breast cancer subtype because it is not biologically stable or consistent. We can see there is only moderate concordance with local and central testing for HER2 low. In DESTINY-Breast04, central confirmation for HER2 low status was required, and you can see about an 80% concordance between local and central testing, with the majority of discordant cases being read centrally as IHC 0. Within this global retrospective series from Dr. Viale and colleagues, you see a little over an 80% concordance rate for HER2 low status, but this stands in contrast to what we just recently saw this morning from the TALENT trial with only a 57% rate of concordance for HER2 low. We can also see this gets more complicated when we look at concordance between HER2 zero and 1+, as shown by Dr. Rim this morning, with only a 26% concordance rate for diagnoses between HER2 zero and HER2 1+ staining. It's really important to note that HER2 zero does not mean complete absence of HER2 staining. It does allow for up to 10% faint staining, leading to this terminology of HER2 ultra low. We can also see that HER2 is unstable over time. When looking at changes from the primary to metastatic setting, you can see that some tumors go from being HER2 zero to HER2 low, and some the other direction. The reasons for these changes could be multifactorial. It could be led to differences in HER2 testing, HER2 heterogeneity, and potentially even biological evolution of the disease that can be influenced by treatment. We can also see this in the preoperative setting, where we saw in Penelope B a shift from the upfront core biopsy to the time of surgery in almost 40% of cases, and in TALENT this morning we saw about a shift in 50% of cases. You can even see discordance within an individual patient from tissue collected at different locations at the same time point. This was a rapid autopsy series from 10 patients where they saw that HER2 status of different metastases was highly variable within individual patients, with HER2 low and HER2 zero lesions being seen at the same time point in 8 of 10 patients. You can even see discordance within an organ within an individual patient. And so when looking at the liver, you can see 5 of 6 patients had heterogeneity in HER2 status from different segments of the liver, suggesting that biopsy location can even influence HER2 low status. So, given the evolution of HER2 low that can occur over time, and given that an individual patient can even have different HER2 status in different locations at the same time point, how do we even define HER2 low? We certainly have the static definition that we know is defined by immunohistochemistry, but in real life, we need to think about the patient who sits before us who has multiple different tissue biopsies with different results. Which one do we use to make a decision about selection for trastuzumab deruxtecan? We have some suggestions that could help us from the data presented from DESTINY-Breast04 in the spotlight session today, where we saw that T-DXd, when compared to standard chemotherapy, had consistent benefit regardless of the tumor sample utilized. In DESTINY-Breast04, about a third of tumors came from primary tumors, and about 2/3 of samples came from the metastatic setting, with only 10% of the samples being acquired just prior to initiation of study treatment. Additionally, about a third of samples came from prior to 2019, the year the study began enrollment. So given the complexities of assessing HER2-low and some suggestions of activity of trastuzumab deruxtecan irrespective of the time point of tissue collection, we need to think about a practical definition for how to practice in clinic. One potential definition we could adopt was to declare a patient having a HER2-low tumor if they've had HER2-low expression on any prior specimen during the course of their disease. This would mean that for metastatic patients, about 80% of patients could have a HER2-low tumor. We will need further data to know how trastuzumab deruxtecan does perform if such a definition is adopted. Our next challenge, however, is going to be how low can we go? We've seen these data from DAISY suggesting that patients who have HER2 IHC 0 tumors can even achieve a 30% objective response rate, but we don't know if those patients who are responding have ultra-low tumors or if, in fact, some of them have absolutely no HER2 expression and are still benefiting from trastuzumab deruxtecan. We will get more data from DESTINY-Breast06, which does include a cohort of patients with ultra-low expression, so more to come with this. This is likely going to shift our view of HER2-low over time. We've already gone from a paradigm where we've thought of HER2 as being either positive or negative to a point today where we think of HER2 as being IHC 0, HER2-low, or HER2 positive, and soon could add a fourth category of HER2 ultra-low. But I think in the future we're going to need to move towards a more continuous and quantitative assessment for HER2-low to make decisions about use of trastuzumab deruxtecan. And so the question is, how are we going to get there? We saw some data from a novel quantitative assay in this spotlight session this morning looking at reverse phase protein array technology on FFPE tissue, and they saw that when they scored HER2 0 tumors, then in fact 30% of the hormone receptor negative and 40% of the hormone receptor positive tumors actually had modest amounts of HER2 expression. This assay and other quantitative assays will need prospective validation, but in the future could help us identify those patients with ultra-low expression that benefit from trastuzumab deruxtecan. So in conclusion, HER2-low is not a new subtype of breast cancer. We can see that there are only marginal differences in clinical pathologic features and prognosis after correcting for ER. These tumors are also not biologically distinct, nor are they biologically stable or consistent. We can see that HER2-low and HER2-0 lesions can coexist in many patients, even in the same organ, even at the same time point. And HER2-low status does change over time and does increase with increasing levels of ER expression. So while HER2-low is not a new subtype, it is a biomarker. It is not a biomarker identifying a new oncogenic driver, but is rather identifying a target for novel antibody-drug conjugates that can deliver potent cytotoxic therapy into HER2-expressing cells and have robust clinical activity. That being said, novel quantitative HER2 assays will be needed as a definition of HER2-low is likely to evolve over time. Thank you very much.
We now will take a poll question. We'll do it again. Open your SABCS app. Click on, I think it's Dr. Curigliano's presentation. And at the bottom, is Dr. Tolani? At the session. Click in the bottom of the session. And there was a question and answer poll.
Which one?
Click one more.
There is a button here. I did that. Okay.
Click one more. Click one. Click one. Okay.
Yeah.
One more.
One more.
One more. Okay. Standing. Are you guys ready for the poll?
Sure.
Yeah.
Okay. Clicking.
Okay.
All right.
Very good. We have time for a few questions, but beforehand, we have Ms. Patricia Spears, who's a patient advocate at the UNC Lineberger Cancer Center, to give the patient's perspective on this debate.
So I think from the patient perspective, this is a really important issue, and I'm really glad they added this to this program. And I think it's really important to get this right, though. And I think we really need to get it right. Whether it's an entity or not, I think it is a biomarker for treatment. And so for metastatic breast cancer patients, that can really benefit from this, I think it's really important, especially with those that I know that are triple negative, trying to find out if they're HER2 low. It adds another treatment option. So it's really important to get this right. But it's also important as we go into, possibly an early stage setting with some of these ADCs that do have some harms associated with them. We don't want to over-treat patients either, and we really want to just treat the patients that might benefit. So I think in all of the debates that we've seen, I think it's really important to keep in mind those benefits to the metastatic patient, but those harms that might be seen in the early stage patients. And CT scanning for changes in lung is not prevention of the lung disease, so I think we really need to readdress those issues too before we go to the early stage setting. But I think getting this right, we rely on the pathologist for our treatments going forward, 110%, and we rely and we think that that's accurate. So I really want it to be accessible to everyone and equitable among everyone, gets access to whatever test comes out for this. So,
Thank you very much.
And exactly as Patty said, Dr. Rim's laboratory is at the cutting edge of pathology research. But as Patty said, we need to make sure that all patients have access to reasonable techniques. And we can add a pro and a con for the pathology discussion, but a high level of accuracy of 85% is nothing to sneeze at. So we need to keep that in mind as we go back to our offices on Monday and try to investigate and see who is a HER2 low. Since HER2 low can be changing through different points of life throughout the patient's journey, it is important to keep that in mind instead of agonizing over a 110% accurate number.
Great. I think we have time for a few questions before we end. 3.
Thank you, Dr. Brusky. And I want to thank the whole panel, but particularly the format of this discussion. I'm Michael Dugan. I'm a pathologist with a biotech company called Biocept in California. I was a resident with David Rim at Yale.
Hi, Mike.
David, you've made an amazing contribution to pathology and to oncology. And I'm reminded of 20 plus years ago writing a paper on HER2 expression in pancreas cancer, and at the time there was an active, a very prominent pathologist who argued that if it wasn't FISH amplified, it wasn't real HER2, it was artifactual. And that probably held back a lot of the treatment for people with pancreatic cancer and that was HER2 positive for maybe a decade or more. Yeah. I wonder if you could speak a little bit to that and how much this work might change the treatment, not just of breast cancer, but of many different solid tumors.
Thanks, Mike. I would comment that we've actually started to look at HER2 and other cancers, and 30% of lung cancers has levels of HER2 that are comparable to low HER2 in breast cancer. So not just the 2% that are mutated, but I think lung cancer is where we'll look next. We haven't looked at pancreatic cancer, but it's certainly an open question. And clearly, there are HER2 levels of expression that are not amplified in many other cancer types.
Thank you again.
Okay, how about we also take a question from microphone 4?
And that will be the last question.
Michael Ignatiadis, Jules Bordet Institute in Brussels. Excellent session, excellent debate. I have a question, a comment and a question for Dr. Curigliano and Toleni. So we see discordant results between the different studies when comparing HER2 low versus HER2 zero. And the question is, when we don't have an assay that can accurately define the two entities, HER2 low versus HER2 zero, I guess this is what explains all the discordant results, right? So I think we will need to redo all these studies again once we have robust validated assays. Otherwise, all results will be flawed by the lack of a validated assay. What are your comments?
I think that's an excellent point. I think it's really challenging to define HER2 low. I think the other challenge is that many of these are all retrospective studies. They also did not have central pathology review. And so you're going to have, given just the vast discordance, I think you're exactly right that that's what's leading to differences in outcome. I hope we will be able to see a quantitative assay in the future. And you're right, then we will be able to really be able to understand with central quantitative assays if there are distinctions.
So just to complete, in the Destiny-06, we have a central assessment over too low. And as you know, the discordant samples are not eligible for the study. So I believe the Destiny-06 will give a response to your question. And the most important response is related to HER2-0. Because the real risk is here that many patients that actually are 0 will become 1+ to access to therapy. And I don't want to give a treatment that will not work to a patient that is not eligible to that treatment. So assessment is key to better define patients who may derive larger benefit from this type of excellent therapy.
Great. I want to thank all the speakers for what was an excellent session. And thank you all for attending. And just a reminder, the posters associated with this session are present outside for viewing. Thank you very much.